Rick Unger here at the second annual Forbes Healthcare Conference, joined by Dr. Gina Villani, correct?
Villani, yes.
Villani, I got it right. Gina, can I call you Gina?
You sure can.
I'm going to insist on it, but you have to call me Rick in return.
Okay.
Okay. Gina is the CEO and the chief medical officer, right, at the Ralph Lauren Center, which I happen to think is one of the better institutions here in New York City. I'm going to start by asking you to tell everybody about the Ralph Lauren Center.
Okay. So the Ralph Lauren Center started 10 years ago. This is our 10th anniversary. And it came about because a gentleman named Harold Freeman, who was a breast surgeon in Harlem, noted, and rightfully so, that African American women were dying from breast cancer.
Right.
At a different rate than white women right down the street. And around that time, Ralph Lauren had a friend who had actually died from breast cancer. So Harold Freeman went to Sloan Kettering and said, we need to do something about what's going on in Harlem. Ralph Lauren had gone to Memorial and said, I have a friend that died from breast cancer and I want to get involved in cancer. And Memorial Sloan Kettering put the two of them together, and they came up with this idea of opening a cancer center in Harlem that really was geared towards taking care of minorities and underserved populations.
But it's gone well beyond breast cancer at this point, yes?
Absolutely, yes.
So in looking at the organization, I see you're primarily involved in two critical facets, actually, of the entire cancer process, if you will. The first is the importance of screening, and I know that you do a lot of community outreach in this, correct?
Yeah.
And how do you go about that? How do you get people to come in and get screened?
Well, I'm going to step back a little bit and say, you know, this year we're not even calling it screening, because I think that to just say, come in, have a colonoscopy, have a breast exam and a pap smear really isn't enough, and especially for the populations that we serve. So we've taken to calling it cancer risk reduction, because whatever it takes to get somebody in the door.
And you find that works better?
We do, because then even for the providers, it makes us think about, we've got a person in front of us, they may be coming for a colon cancer screening, but let's look at, do they smoke? Are they obese? Because we know obesity is a risk factor for many cancers. Do they have hepatitis? Because hepatitis is a risk factor for liver cancer. What's their family history? Do they exercise? And really looking at everything that impacts their risk of getting cancer, and then not only doing those traditional screenings, but see what we can do to lower those factors that are increasing their risk.
How do you, I know how hard it can be, particularly in that community, to get people to face up to potential problems and come in. Once you get them in the door, you've taken a major step forward. Right. How does your outreach work? How do you get folks to come in the door?
Well, so I think that you know, in the healthcare field, we're very easy to look at the patient and say, the patients don't want to come in, they're a difficult population. But what I've seen, and I've worked in a lot of underserved areas, is that healthcare is not very inviting to patients in general, but especially people who have a lot of other concerns on their mind, like their jobs and how are they going to feed their family, and et cetera, et cetera. And so what I've seen is that a lot of institutions are, you know, the minute you walk in the door, you're met with a uniformed officer who wants to see your photo ID, right?
That's absolutely right.
You know, that's not a very inviting situation, right? So a big part of what we do, and Mr. Lauren has helped with this tremendously, is if you come to the center, it's beautiful. It looks like Ralph Lauren's living room, right? So right then and there,
that's
and somebody
a nice
walks
living
in,
room to have.
yeah. And it, you know, that says we respect you instead of a place that's cold and sterile and not so clean.
So in addition to that, in addition to the setting the environment that people are more likely to want to come in, and you're so right, people don't want to face up to even what they know may be happening. As long as they don't know, it seems like it's not there. The minute they do know, they have to confront it. I know how tough that is. When you have them there, is the, we'll call it the hospital, the clinic, is it set up to perform chemotherapy, to perform surgeries? Can you do full service radiology?
No, we can't do surgery. We refer out for our surgery and our radiation. So it's really two clinics. I don't even like that word. It's two centers in one. The first center is that cancer prevention and screening. So in that part, we have a full colonoscopy suite. We can do pap smears. We have a breast surgeon. He can do fine needle aspirates and minor procedures. and then we work on that risk reduction. And then the second piece is the cancer treatment, where we can give chemotherapy. We have a beautiful infusion room, and then we'll help navigate someone to surgery if they need it, to radiation if they need it. So we're really taking care of them. On top of that, I got to tell you something else. Besides those services, we have a food pantry, because our patients that are getting chemotherapy, it isn't even always a matter of finance. It's you don't feel good, you can't get to the store to get the groceries. So we have a food pantry, and if you need it, we'll send you home with a bag of groceries.
Who thought of that? What a great idea.
You know, I think that's happening in a lot of places. And in fact, Sloan Kettering had started with a grant, the food pantry, and then we got an additional grant from the New York City Council to really expand that food pantry.
I would imagine a fairly healthy percentage of your patients are coming in without some form of health insurance. Is that fair?
Yes, and so what we do is if people call and say we're uninsured, we say just come in, because we also have a financial navigator. And we found that 50% of people who think they're uninsured or uninsurable,
right,
we can get into insurance.
Either
and now,
via Medicaid or...
Right.
Okay.
Exactly, mostly Medicaid managed care. But now with the Affordable Care Act, we've been trained in the exchange, and we're helping people enroll in an exchange product. So we have the food pantry, we have a financial navigator, we have a psychologist.
So your
that comes
navigator
once
is a trained navigator for the healthcare exchange?
Yes. We have a psychologist that comes once a week to meet with patients regarding psychological aspects of a cancer diagnosis.
Well, I have to ask you, do you view the new law and the existence of the healthcare exchanges as a good thing, beneficial to what you're doing?
Yes and no. I want to tell you a little story.
Okay.
When I started at the center about a year and a half ago, I did a secret shopper. And I made up a patient who had stage 4 lung cancer, and they had a Medicaid managed care. So in New York, that would be considered an underinsured patient.
Right.
I had an employee pose as their son. I had them call 11 area hospitals and say, my father has stage 4 lung cancer. He needs to see a medical oncologist. I need to make an appointment. Mm-hmm. And we created a grid of the wait times for his father to get into care, how many times he got transferred on the phone. We had one hospital he was transferred 9 times. Most people would have given up after 3 or 4. And what we found was that a lot of the hospitals were really failing. And we had a wait time of 53 days.
To begin chemotherapy?
To be seen by a medical.
Or to even be seen, really. So does this make it better now, or does this make it worse?
Yeah, so to your point about the Affordable Care Act. So the Affordable Care Act is expanding Medicaid. Mm-hmm. If we already have an issue with access to care for Medicaid patients, that's not going to change, right? Just enrolling more people into Medicaid isn't going to change that access issue. And then I can just speak for the center that we have been approached by insurance companies to participate in products, right? And the lower tier products, the reimbursement rates for those products are very low. They're 75% of Medicare rates. Sure. You know, there's data that says people with Medicare are having a hard time accessing care. Right. Now you're bringing in a population that's got 75% of Medicare rates. So I'm a little concerned. I mean, I think it's a good thing for people to have insurance. I wish there were more places like us to deal with those patients. So I have a concern that we're going to sit back and say, look, we insured this many people, but insurance doesn't equate to access.
So it actually leads into an interesting area, at least interesting to me, maybe to you. It does always seem that the doctors, the physicians, are kind of the lowest point on the totem pole when it comes to who's going to get hurt in the medical system as we know it today. The doctors are the first place we turn to cut costs, to pay them less, Medicaid or Medicare, as the case may be. And yet, the doctors are the one element of the system that you can't have a healthcare system without. You don't want to be without a hospital, but you can be without a hospital if you have a doctor to treat you. You don't want to be without pharmaceuticals, but you can be if you have a doctor. You can't have a healthcare system without physicians. Why do you think it is that we go first for the doctors?
Because we never put up a fight. I mean, if you look at, there's
And why is
models,
that?
because how we react to cuts in reimbursement is just increased volume. We just work harder. I mean, that's been,
But at some point,
shown.
you run out of that capability, don't you? There
Well, then
are
what
only
happens
24 hours
is-
in a day.
So then what happens is the quality of what you're doing and the time that you spend with the patient, you just keep cutting
Sure.
that, and that goes down and down, right? But, I'm not a economics expert, but I did take a class in it, and I remember our professor saying that this has been studied, and doctors, they won't fight. They'll just keep increasing their volume to make sure that their income level remains the same.
So most doctors who I speak to, and I talk to them quite a bit, will say that they don't fight because they view it as an ethical issue, which I can appreciate if it weren't for the fact that the same doctors are turning away Medicare and Medicaid patients because it doesn't pay enough. Isn't that inconsistent?
Yeah,
How do you
really-
say that you have an obligation to treat people, no matter what the cost, but I'm going to say no to these people?
Well, yeah, that's an easy thing to do, isn't it? You speak out of both sides of your
It's
mouth.
both sides of your mouth. So where that leads me is if doctors are going to do that, and if they come to realize they're really, you can't make this ethical argument. If we're going to turn away certain types of people, why don't doctors ever go on strike?
I have no idea.
It's an interesting thing to think about, isn't it? Because wouldn't it all change immediately if Senator so-and-so, if he or she got a call from mom and said, I can't go in to see a doctor. They're on strike and I don't feel good. Think things might change?
Yeah.
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 It's actually a question I'm going to be asking a lot here at the Forbes Healthcare Summit, because I'm actually fascinated by this. Doctors have this tendency to believe that they can't do things like that because of the ethics of their profession,
Exactly, I was just thinking
which
about
I
that.
admire, except that they don't practice those ethics when it comes to certain elements of society, which means that they don't make any sense.
Right.
Okay, so just quickly, let's get back to what do you want to tell us about the Ralph Lauren, I would say Lauren, I've always said Ralph Lauren, it's Ralph Lauren.
Right.
Institute that we haven't talked about, because I want people to know as much about this as they should.
Yeah, so I think the other thing, so we have this whole model of providing service and quality care, but the other thing that we're really interested in doing is affecting healthcare policy. We have this beautiful model of how to take care of underserved populations in the community to try to do it in the most cost-effective way possible. And frankly, we can't survive without philanthropic input, right? And everybody in healthcare needs some philanthropy. But why can't we survive? Why can't we go to work, see patients, and live off our revenue? And the reason is because of the way that the people we care for and the way that we're paid. So we want to do work in payment reform. We want to do work in creating different models of payment. Right now we have a grant into the state to make the Ralph Lauren Center a cancer medical home. Mm-hmm. Just like in primary care, we have these medical homes. Well,
tell us how you would go about that.
Right, so we in essence are a medical home. We're taking care of all things cancer, right?
And you're bringing in doctors from all specialties within oncology, within cancer.
Right, we're trying to, and more than that, we're starting at, let's see if we can prevent it, right, with our cancer risk reduction. And then if we can't, we're going to treat them, we're going to navigate them, we're going to make sure that people stay on track, that they get their care, that we're giving quality care, and that we're addressing all the social determinants of health, right? So we're not getting paid to have a psychologist, we're not getting paid to have our navigators, we're only getting paid for those physician visits. But a medical home pays you for what you do beyond. And I think that if we could create that model that says, this is financially viable to do this, to have these centers out in the community, to take care of this population, we can eventually save the system a lot of money, right? Because we work with a population that traditionally goes to the emergency room, that traditionally, doesn't address end-of-life issues, is not in hospice care, and all those things that are really expensive, right? So if we can have medical homes for primary care and say this is a cost-saving measure, what happens when somebody develops an illness where they need a specialist? It all falls apart. And oncology, you know, the costs in oncology are incredibly high, right? So this is an area where we should be looking at those models, not just because they're good for the patient, but they're financially sound. So ultimately, we want to really create some sort of model that shows everybody else, don't shy away from taking care of underserved, underinsured patients, right? You can do this.
Yeah. I hope people watch this. It's so important what you're doing and what you're talking about. We've been talking with Dr. Gina Villani. I encourage you to look more into this operation. It is doing great work, needs philanthropic assistance to make this work out, and I hope you'll look into it.